you. I have the following disclosures. I am going to be describing really off-label use of the Melody valve and talk a little bit about how we've been using it as an expandable valve. Just to set the background, obviously we've been talking a lot about the different types of conduits that can be used for right ventricle to pulmonary artery reconstruction. But all of these are really conduits that come in a fixed size. That is, they don't really grow with the child unless you believe that they're living conduits, as was discussed in the previous session. But because of this, there is a tendency for surgeons to really try to oversize these valves a lot at the time of implantation, to get the biggest size valve we possibly can get and be able to close the chest. And in the situation where you placed a valve in a young child and the valve becomes, or the conduit becomes stenotic, our colleagues in the catheter lab can obviously improve the size of that to reduce the gradient or replace the valve with a transcatheter valve. But the problem remains, that is, our tendency to oversize the valve at the time of implantation. Are we really doing a disservice to our patients? Now, when we traditionally talk about patient-prosthesis mismatch in surgery, we're talking about patients getting a valve that's too small for their body surface area. That's what happens in older patients undergoing cardiac surgery. But there's increasing evidence that patient-prosthesis mismatch can also occur on the other end. That is, if you oversize the valve too much, that there can be early deterioration. This is data here from a study that we performed that showed if you take younger children, so these are children that are 10 years of age or less, and you look at the size of the valves that were sometimes implanted in these children and look at the deterioration rates, the rate actually goes up with the larger size valves. And with z-scores that are greater than 2, we find positive 2, we find that their deterioration rates are higher. So that what we found when we've gone back to look at our series and included in there also decellularized homographs as well as regular homographs compared here to transannular patch, that are freedom from structural valve deterioration. So this should be distinguished from reoperation. You might not reoperate on a patient if their valve is leaking until they develop right ventricular dilation. But if you look at whether the valve leaks or not, the structural valve deterioration rates were alarmingly high. Now, for most patients, this is okay. You wait until they get old enough to be able to place a transcatheter valve. But in other patient populations, we find that we can't get by with that type of approach. So we started to consider, is there a way to create, with existing technology, an expandable valve? And the venous valve, for many reasons, is a valve that is meant to function at a range of diameters. As you can imagine, when you're standing up, you have a higher pressure in your lower extremities. The valve needs to remain competent. And then when you're lying down and the pressure goes down to very low and the diameter of the vein comes down, it also needs to function. And so this is obviously something that was easily testable, and the Melody valve was our easiest target for a venous valve. And it was obvious in the cath lab when we were working with our colleagues that this valve really does maintain competence at a range of different diameters. So we thought, is it possible to be able to take advantage of that characteristic of the valve and be able to use it as an expandable valve over time? We asked a similar question of other types of valves, pericardial constructed valves, and when we did some testing on the back table, we found that valves that are meant to function, pericardial valves that are meant to function at a size of 29 millimeters, really don't fit quite as well when they're much smaller than that. And so we didn't pursue the sapien valve, although there are other institutions that have used the sapien valve for a similar purpose. But the hypothesis that we wanted to test was, sure, you can get a valve to work at various diameters prior to implantation, but after you put it in the child, will it still continue to work years after implantation? Just to sort of reiterate why these valves seem to work well, we did a little bit of investigation in the lab to look at the coaptation height at different diameters of the valve, and found that really the coaptation height maintains at greater than 1 to 2 millimeters at multiple diameters until you reach at least a millimeter or two beyond the native diameter. At that point, once you get beyond the native size of the valve, it starts to leak. So you want to constrain that valve to beneath its native diameter. This was the issue with an unsupported valve, such as the Contegro valve, that we feared it did not have enough support to be able to maintain these same characteristics. Further finite element model analysis suggested that it's really the commissural post height of the venous valve that allows it to function at a range of diameters adequately, and the thin leaflets really prevent stenosis. And this is finite element modeling done on a bicuspid configuration, but the same applies for a tri-leaflet configuration. So who are the patients that would really benefit from this? Clearly, the older patients who can get a transcatheter valve, there are different options, and I think that was less of a concern for us. Our concern was really the younger patients, less than 10 years of age, but certainly the group that are neonates to 5 years of age, in whom we're doing our RV to PA conduit replacement, in whom you really need a competent valve. We know from a transannular patch experience that not all patients need a competent pulmonary valve for a period of time. But these are patients that have elevated pulmonary artery pressures, so whether it be pulmonary hypertension, whether it be distal pulmonary artery obstructive disease from unifocalized vessels in a pulmonary atresia patient, patients with airway obstructive disease who intermittently develop nocturnal hypercapnia and may have intermittent pulmonary hypertension related to that, patients with right ventricular dysfunction, tricuspid regurgitation. You get the idea. Patients in whom you really want a valve to work, who are young, and you want this valve to work beyond a couple of months. In our experience with our homografts, the valves fail relatively early, and the smaller the patient is, the quicker those valves will fail. These are the patients that we applied this strategy for. So then how do we prepare the valve? Well, there are a couple of different strategies that we used. The first was to take the valve and implant it within a tube graft, kind of like the way our colleagues in the cath lab use it, and that failed miserably. There were perivalvular leaks that developed. We were implanting it within a Gore-Tex graft or within a HemoShield graft. These are cloth grafts, and perivalvular leaks wasn't pretty. So we started going to direct surgical implantation techniques, and in order to allow surgical implantation, we either had to add a cuff on one end. This valve is not really meant for surgical suturing. The crowns make sewing a very tedious task. So we either had to implant a disc on the proximal and distal end of the valve, or we had to trim the stent. And we sort of settled on the trimming the stent, and I'll show you some of the tips in just a second. But this is a very basic implantation technique. Here's the valve. The distal end of the valve has been trimmed, and it's sewn to the pulmonary artery directly. On the proximal end, we just take the back wall of the valve and suture it to the right ventricle directly. And that allows the valve to sort of sit in a straight configuration. This valve doesn't really have much bend to it, so you want to get it on the straightaway and then reconstruct the top of the graft then with a proximal hood. And so with this type of strategy, we were able to construct the valves. Once we place the valve in, we then balloon dilate it to a Z-score of 0. That is, we're not trying to oversize the valve. We're trying to get it to a size that we appropriately want. And so we size it just before completing the proximal hood. There was a period of time where we were adding a distal skirt to the valve. The disadvantage of a distal skirt is that it makes it a little bit longer. And so in the younger patients, now you're stuck with a valve that's practically sticking out of the sternum, and you got to figure out how to put it down onto the right ventricle. And we found that it really wasn't necessary. The distal trimming of the stent and suturing of the material directly to the pulmonary arteries was adequate. So technical lessons learned: don't implant it within a tube graft because of the perivalvular leak. We didn't need a distal skirt, trimming the crowns, using a proximal hood to reconstruct rather than trying to get the entire valve to anastomose to the right ventriculotomy, and then finally right-sizing the valve rather than trying to oversize the valve. So now some of the results. I'm going to pool our results for use of this type of expandable valve in all positions, just to give us a sense of how this functions as an expandable valve in children. So we implanted this in aortic, mitral, right ventricular outflow tract, and tricuspid positions. The right ventricular outflow tract indication that I mentioned previously, that was 20 patients in the series, median age of 1.5 years. There are two patients with early technical failure in the right ventricular outflow tract position. And one patient I mentioned earlier, we were trying to place it in a tube graft and there were perivalvular leaks. In another patient, we were too aggressive with the distal trimming to get the valve to be very short. And I think we inadvertently actually resected a part of the commissural post, which led to early insufficiency of the valve. After implanting the valve, at generally a median about 1.5 years, we've come back for catheter-based expansion of the valve. This is obviously done in the cath lab, so it's not a self-expanding type of mechanism. But the results of this were pretty remarkable in that we found that we were able to get the gradient down satisfactorily in patients who had RVOT implantation. Our indication for going to the cath lab was the development of a gradient in most of these patients, although now we're actually moving towards more prophylactic dilation before they even get into trouble with having a gradient, as we start to feel more comfortable with the results of balloon expansion. And if you look at the profile of regurgitation after the balloon dilation, we find that most of them, despite the balloon dilation, still have preserved valve function, suggesting that the delayed the pliability of the leaflets inside of the Melody valve were retained even years after implantation. When we look at the valve durability now in all positions as measured by freedom from structural valve deterioration, so this is leakage within the valve, not reoperation, we found that it was pretty good. Again, perivalvular leaks are technical in origin, whereas central regurgitation, in my mind, is a problem with the concept. And so there's reasonable central competence of this valve despite multiple dilations over time. The histology of the valves that came out really tells us a little bit more as to why they retain their ability to maintain competence. If you look at the histology on these valves, the leaflets remain very thin. They're actually quite acellular. Even at the oldest patient that we've resected is 3 years out from implantation. You'll know you don't see it very clearly here, but there are cellular infiltrates, and there's actually some calcification in the wall of the Melody itself. But the leaflet material is acellular and has no cellular infiltrate in it. Now, there are probably some implications for not having cells in the leaflets, and I think that's something that we're going to continue to watch out for, and particularly the risk of thrombosis. We maintain patients only on aspirin, not on any more anticoagulation, and we haven't seen thrombus develop in these patients. And of course, there's a risk of endocarditis, which we have seen in our transcatheter Melody valves. So far, we have not seen any in the RVOT position. And we've speculated a little bit as to why there might be differences between the transcatheter versus the surgical melody valves. You know, when you're placing one of these valves in a conduit, there's a dead space, a potential dead space that gets created between the conduit, the melody valve, and the conduit. And perhaps that is a nidus for seeding of bacteria. When I've gone and removed some of these, I found that it's not only the leaflets that are infected, but it typically starts from the outside of the valve and moved its way in. Whereas with a surgical implantation, you don't have that dead space. It's essentially up against the tissue surrounding the melody itself, and perhaps that makes it less amenable to infection. But it's still early. I think we're very aggressive about antibiotic prophylaxis. You know, the pediatricians that don't want to treat ear infections with antibiotics, no, not in my patients. That kind of aggressiveness, I think, has perhaps played a role as well. So I'll just summarize here by saying the current options for RVOT reconstruction are adequate for some patients, but in some of our patients, they really don't necessarily cut muster. And so the valve oversizing in these patients, I think, is an issue and is worth considering how we can avoid that. The venous valves, they function well as expandable valves in multiple positions. And so because of this, we've pursued the strategy of right-sizing the valve at the time of implantation, with then coming back and enlarging them at a later time point. And with this strategy, we've been able to preserve valvular function and delay reoperation for a period of time. And it remains to be seen how many times we can come back and redilate these valves. Our oldest patient, who's now out almost 7 years, has had a dilation 3 times, and is still, the valve is still functioning. But I'm sure at some point it may lose that ability. Thank you.